So thank you, everyone. I think we need to switch into English because we have a very special guest panel today with us, and we are connecting with the UK. We have our friends, our colleagues over there. Good morning, Mr. Konrad Dobsuds. Good morning also to Piers Ricketts. Mr. Piers, thank you so much for being with us today. So I'm going to take a seat here in the auditorium because I want that to be a dialogue between a team of peers, people working on the healthcare system in the UK, working in networks, and here, Spain, a huge healthcare system with a lot of innovation experience that want also to share our experience with you. So in order to make a brief introduction on our speakers today, our guests, let me talk first about Mr. Piers Ricketts. Mr. Piers is an experienced healthcare innovation expert with a lot of professional experience in top firms and top consulting firms, and he has been CEO of the Academic Health Science Network. He will be talking about what is this network, what are they doing in the UK, in the NHS. And for those of you who are familiar with ITEMAS, our innovation network here in Spain, I would say there are some similarities that I want you to connect with and to make the link with also. We also have with us Konrad Dobsuds. Hello, Konrad. Konrad is the he's the head of innovation, customer solutions in the UK for Novartis. He has a long experience also in innovation, especially with blockchain, AI, and top projects within the healthcare system. And he has recently started to lead a group of people, a network within Novartis and the healthcare system in the UK, which is called Biome.
Thank you very much, and good morning, everybody, and I hope you can hear me all right. So yes, good morning, my name is Piers Ricketts, and I'm representing the Academic Health Science Network in England. We are the innovation arm of the UK's National Health Service, the NHS. We employ about 700 people, and our role is to support the adoption and spread of proven innovation. So this isn't the very early stage things, but these are medicines, technologies, clinical interventions, which have already received some kind of regulatory approval, but they aren't yet fully adopted.
Well, so super to be here. Good morning, everybody. I tell you 50% of the time, I don't know what I'm doing every day, but the other 50%, I know where the Biome sits. So the Biome is the Novartis Innovation Lab and Digital Innovation Lab. So what we do, we have a network around the world, and I head up the Biome in the UK. The Biome really stands for accelerating innovation. So in a way, it is the industry side of what Piers is doing. It's similar, right? We have got a large network that we built up in the UK and globally that doesn't only include partners like Piers and the HSNs in England, but it also includes international companies like Microsoft, MasterCard, and we're talking to Tesla as well.
Think about where we are now, and Spain, I'm sure, will be similar. The difference is in the UK, we have a system which is centrally funded, although it's regionally delivered, and it's paid for out of current taxation. So it doesn't have an insurance model as many countries in Europe do.
Makes sense. So Piers, you are facing quite an overload on demand, especially after COVID, and that is making you try to establish connections and networks in order to put innovative, evidence-based interventions on the NHS kind of innovation for everyone. That's what I understood.
That's right. I mean, there was a demand for this before COVID, because there's a statistic from the World Health Organization which says that by 2030, the world will be 18 million, short of 18 million medical professionals or care workers across the world. So we had the problem before COVID, but COVID's made it harder, and it's exactly as you've summarized.
Thank you. I think it's along similar lines, but where we from the Biome really come in is being that partner to the healthcare system, and I think that's a slightly different approach. So in a traditional sense, pharma, in quotation marks, would knock on the door with a product, for example, or a conversation about a certain indication. Of what the Biome does, none of that happens initially. What we're talking about, how can we help the NHS with the capacity problem, for example, with the patient weights? So that is completely, that's an agnostic problem. So how can we help solve that? And the IESE-Ns for us, from a Biome perspective, and Novartis really, are a conduit and are that gatekeeper of making sure that what comes through actually works, which is very much in the function of the IESE-Ns, right, Piers? So that's what you're supposed to do. And that's why the collaboration between the Biome in particular and the IESE-Ns makes absolute sense for us. It's the right way to go. Plus, one addition, there is the expertise, not just Piers, but this whole team and all the IESE-Ns. They have that experience to actually vet a, say, digital solution. Does this make sense? So the entity or tactic that we run in the Biome, which is called the evidence lab. And that is something where we test in particular digital solutions within the healthcare system, whether they work or not. And they're tested on 4 categories: patient adherence, to the solution, patient adherence, patient efficacy, patient experience, and clinician experience. Those 4 elements we're testing. And it's leaned really on almost clinical trials in terms of protocol. So one initial test that we undertook with and went in with Pierce's team was a capacity solution. So risk stratification of dermatology patients, called Penguin here in the UK. And maybe Pierce, you want to talk about what the process is in the IESE-Ns of how then things get into the trusts, and how do you further interest for something?
Yeah, so if you imagine dermatology is a specialty with many, many, many outpatient follow-up appointments. So has your skin lesion changed over time? Is it okay? Does it need follow-ups? So traditionally, a patient would have a follow-up appointment in the hospital every 6 months, 12 months, perhaps even more often, to monitor whether their skin lesion looked like it was becoming cancerous or whether it had healed after surgery. What this invention or innovation has done, it's a series of questions by which the clinicians can ask the patients for indications of how their condition may have changed or if it stays the same. So clearly, if you write in once a week and you say that it's stayed the same, then you may not need the support, and therefore you free up clinician time to look after people who do need attention. And so we understood this. We got together a series of clinicians from the teaching hospital in Cambridge, Addenbrooke's, part of Cambridge University Hospitals, and we showed this to the consultant dermatologists. And in this instance, they quite liked it, but they didn't feel that there was enough evidence in terms of the outcomes or the safety to merit changing their internal practices to use this system. The Novartis team and the cardiovascular team at NHS England have identified a number of patients, and it's a 6-digit number, whom they are going to try to give this medication to over the next 2.5 years. And it's done on a population health basis. So previously, we would have said the East of England represents 6 million out of a population of 60 million, so you have 10% of the number. But this time, we're actually looking at the disease burden in different parts of the country, which means that the northwest of the UK and the northeast, where typically you have people with chronic cardiovascular and respiratory problems, that's where we have the most patients that we want to offer this to. And in some of the more affluent parts of London, there'll be the smallest number because we don't think that we have quite so many people. So First of all, the new thing is that the resource is directed at the areas of the population we think will most benefit from this. And there's been some quite serious population health analysis which has gone into identifying those numbers.
As in all large organizations, also in Novartis, we've got change management areas, right? I mean, let's just be honest and frank about this. And what we're trying in the biome is really to run this entity as an internal startup almost. So we've set ourselves some targets of how many patients we want to reach with initiatives that we're running as a unit. We've got a set of KPIs that we're going after as well. A very limited amount of those are commercial. They're more on the how much investment have we brought to startups we're working with. So that's non-Novartis investment, so that's a different KPI. But I think if you then think about the healthcare system overall, I mean, a lot of people, and Piers can reflect on this as well, a lot of people think that the NHS is one unit. It's not. It is very fragmented, just at the least. And although there are now setups with larger regions, ICSs, integrated care systems, where many hospital trusts sit under, that is all new. So everybody's finding their feet. So how do you, as an innovation entity from industry, quotation marks, get into that? How do you have the right conversations at the right time? And how do you move the change needle? Because you have to have so many conversations. And that's where, again, Piers is coming in, right? So we need to make sure we get those patient insights in what we're doing at all stages. Otherwise, we innovate for nobody.
I think don't underestimate the human element in all of this. You know, clinicians are professionals, but they're all different. And doctors and medics and nurses are people. So the way you do this is not by PowerPoint slide deck showing the adoption curve of the benefits that everybody will get. And you need that, of course you need that. But you actually have to work with people. You know, major transformation, it's not, you know, it's technology-enabled transformation, it's, you know, medicines-enabled transformation. But this is difficult. You have to work with people. You have to make sure they're all on board at the start, and you have to bring them along with you. And whether, you know, if you look at the inclisiran example that I talked about, 10 years ago, we would probably have said, there's this great new medication available. It's just received UK authorization from NICE. It costs this much. We recommend to primary care physicians that they use it. And, you know, what do you think would have happened as a result of that? Whereas this time we're saying this is potentially a disruptive innovation, but we've got to do this in a different way. We've got to support the system to understand the evidence and to say what will happen if they use it. So I think it's the human element, the explanation, the communication techniques that you use in all of this change management, on top of the evidence base that you always needed. That doesn't disappear, but I think that's what we've learned over the last 5 years in particular, I think.
Bueno, muchísimas gracias. Yo creo que las conclusiones a las que hemos llegado hoy han sido realmente, bueno, pues cercanas a lo que vivís en vuestro día a día en el sistema sanitario. Probablemente no haya habido nada que realmente digamos, wow, ¿no? Las cosas están cambiando demasiado rápido, pero probablemente tampoco haya habido nada que hayamos dicho, bueno, las cosas están igual que hace 3 o 4 años, ¿no? Por lo tanto, hay cambios. Yo creo que uno de los cambios que estamos viendo es que cada vez se habla más de este enfoque humanístico, este enfoque personal o personalizado a los problemas del sistema sanitario. Es algo que probablemente estáis confrontando, que estamos confrontando en el día a día de las acciones que hacemos. Se sigue hablando mucho de la medicina centrada en el paciente, incluso en UK, ¿no? El NHS, que está realmente haciendo una revolución. También hablamos de profesional sanitario. Yo me he quedado con el cambio cultural, el manejo del cambio cultural en el sistema, como un sistema complejo, como una red de sistemas, incluso entre el mundo de la provisión sanitaria, probablemente de la gestión sanitaria, de las startups, de la industria. Al final es un ecosistema, un conjunto de sistemas que intentamos coordinar y que cada uno de los que estamos aquí hoy intentamos que funcione mejor, intentamos engranarlo. Nos han dicho que no es solo una transformación basada en tecnologías, que tampoco es solo una transformación basada en medicinas, que sobre todo es una transformación basada en personas. Y que para hacer esa transformación y para hacer que pase, necesitamos generar redes de personas, networks, para conseguir que pase. Esto es un reto que tenemos por delante. Yo creo que es una buena señal estar todos hoy aquí porque formamos parte de una red de personas. Nos falta mucha otra gente, pero creo que cada vez más esta manera de trabajar en redes es posible. Y también hemos comentado cómo más allá de la píldora, este billón de pil, requiere de datos, requiere de tecnología y cómo esa medicina basada en la evidencia tradicional es necesaria. Sigue siendo el asiento de todas las innovaciones, pero a partir de las innovaciones que sabemos que funcionan basadas en la evidencia científica, con el método científico tradicional, con la investigación científica, necesitamos una nueva manera de evidencia, una evidencia que está más basada en el real world evidence y en cómo esas soluciones funcionan en el día a día de nuestros pacientes, funcionan en el día a día de la provisión sanitaria. Y necesitamos ese segundo paso, ese segundo, ¿no? Ese giro, con esa nueva evidencia que nos hace falta para poder demostrar a nuestros pacientes y a nuestros clínicos que lo que estamos intentando hacer funciona y sobre todo para saber que funciona antes de intentar implementarlo. Por lo tanto, sabiendo que este hub, este biome de Reino Unido tiene buenos ejemplos, como puede ser esta herramienta de dermatología que han logrado implementar, esta herramienta de oftalmología que también han logrado implementar a través de su ITEMAS, de su red de innovación hospitalaria, en combinación con la red de Novartis, que les está ayudando a llegar a diferentes hospitales, a localizar dónde realmente este testing, esta validación o estos pilotos funcionan, para convencer a los clínicos de los hospitales que realmente necesitan ese change management para que sigan adelante, con datos, con evidencia y también conectando personas que han conseguido hacer ese cambio en su día a día en la clínica, ¿no? Pues una cosa que nos planteamos en Novartis España, y una de las razones por las que yo también me animé a esta transformación, ¿no? Y a pasar a intentar aportar al sistema sanitario desde Novartis, es que creíamos que esto era posible en España. Y como creíamos que esto era posible, una de las cosas que hemos hecho es intentar montar y lanzar esta red de innovación con el liderazgo de nuestros compañeros de Value, de Valor y Acceso, que tenéis hoy aquí muchos compañeros de Novartis que están trabajando, con una red de asesores de innovación de Novartis que trabaja en vuestros centros y con este lanzamiento de una red que nos conecta con otras redes en otros lugares del mundo. Redes Biome de Novartis que nos van a ayudar a detectar soluciones que puedan venir de otros países que os puedan interesar y también a que soluciones que descubrís en vuestros centros que podemos probar que son eficientes, que son realmente que aportan valor al paciente, las podamos escalar a otros centros en el territorio español y también a otros centros alrededor del mundo. Y para eso tenemos Biome. Creo que lo lanzamos este año, ¿no? Se lanzó en el Mobile World Congress y hoy os queríamos presentar, bueno, pues el lanzamiento de esta red a través de la cual podéis empezar a colaborar y a trabajar en estos, bueno, pues en esta nueva manera de pensar, en esta nueva manera de conectarnos con los compañeros de la red de innovación de Novartis y con vosotros, que al final sois nuestra red de innovación, ¿no? en España. Creo que tenemos un vídeo que resume esta red y con este vídeo acabamos para que veáis lo que estamos intentando crear para daros ese apoyo como partners del sistema sanitario que queremos ser. Esta es nuestra apuesta. Creemos que todos esos proyectos de innovación que estáis llevando a cabo en los centros en los que trabajáis se merecen formar parte de una red de innovación global. Creíamos que España, desde su red de innovación, desde todos vuestros centros, desde todas vuestras iniciativas, se merecía poder alcanzar, ¿no?, esta red y poder utilizar tanto esta nueva manera de pensar, esta nueva manera de acercarnos a los pacientes a través de vosotros, como el hecho de que aquello que realmente tenga impacto, que seamos capaces de validar y escalar en España, pueda llegar a otros países. Creíamos que era necesario que trajéramos esta red a España y que dentro de esos 11 centros en grandes capitales del mundo, en grandes países a nivel del sistema sanitario, tenían que tener la presencia de España porque tenemos mucho que aportar a nuestros pacientes, mucho que escalar, muchas experiencias específicas de centros que tienen que llegar a otros. También creo que había mucho hastío, ¿no?, de pequeñas innovaciones que realmente se quedaban en pilotos y que os queremos ayudar a escalar como partners. Va a ser un trabajo arduo, no va a ser un trabajo de un mes ni de un año y que esperemos que probablemente pues, en 4, 5, 10 años consigamos que el sistema sanitario en nuestro país sea capaz de implementar innovaciones de manera escalable, de producir realmente ese impacto en los pacientes en formatos que vayan más allá de, bueno, de estos proyectos que al final quedaban con un impacto limitado a un cierto número de pacientes, pero que no éramos capaces de hacer llegar a todo el mundo. Es la apuesta que hacemos por intentar formar parte de esta red de innovación desde un ser iguales, desde un ser partners del sistema. Y yo creo que con este objetivo de colaboración, con esta ¿no?, apuesta por trabajar todos como miembros de la comunidad del cambio en innovación, podemos concluir esta sesión y agradeceros muchísimo las preguntas que me han ayudado mucho a entender qué es lo que queríais saber y qué queríais conocer de la experiencia de impacto de Reino Unido. Muchísimas gracias.